He takes 7 medications every morning. He lines them up on the kitchen counter in the same order he has for the past 4 years. Blood pressure pill, cholesterol pill, something for his stomach, something for his prostate, something for sleep, something for the pain in his lower back, and one more that he honestly cannot remember the original reason for, but his doctor has never told him to stop, so he keeps taking it. He swallows them all in 3 practiced gulps, drinks his coffee, and starts his day believing that every single one of those pills is keeping him alive. What if I told you that 3 of the most commonly prescribed medications in that lineup, drugs taken by tens of millions of older adults every single day, may be quietly, incrementally, measurably weakening the very organ they are supposed to protect? Not in a dramatic way. Not in a way that shows up on tomorrow's EKG. In a slow, accumulating way that erodes cardiac function over months and years while every lab report continues to say everything looks fine. I am Dr. Arya, and on this channel, Senior Health, I have one purpose: to tell you the things about your body after 60 that matter most and get discussed least. Today, I am going to walk you through 3 widely prescribed medications that have a documented but rarely discussed relationship with cardiac weakening in older adults. These are not obscure drugs. They are not experimental compounds used in clinical trials. They are medications that you or someone you love is almost certainly taking right now. And the connection between these drugs and your heart's ability to function is something every person over 60 deserves to understand before they swallow another dose. Let me start with the one that will surprise people the most because it is prescribed so frequently and so casually that questioning it feels almost unreasonable. Proton pump inhibitors. You know them as omeprazole, pantoprazole, lansoprazole. Brand names like Prilosec, Nexium, Prevacid, they are the drugs given for acid reflux, heartburn, GERD, stomach protection, while taking other medications. Tens of millions of prescriptions are written for them every year, and a significant number of those prescriptions are given to adults over 60, who then take them continuously for years, sometimes decades, often without any reassessment of whether they are still necessary. Here is what these drugs do and why it matters to your heart in ways nobody explained to you. Proton pump inhibitors work by shutting down the acid-producing pumps in the lining of your stomach. They are extraordinarily effective at that job. Acid goes down, reflux symptoms improve, the burning stops, and for short-term use, 2 to 8 weeks for an acute problem, they are genuinely valuable medications. The problem begins when short-term becomes permanent, when the prescription written for a specific episode is automatically refilled month after month, year after year, without anyone pausing to ask whether the original problem still exists. In 2016, researchers at Stanford University published findings that sent a quiet ripple through the cardiology community. They found that proton pump inhibitors were associated with a measurably increased risk of heart attack in the general population, including individuals with no prior history of cardiovascular disease. The proposed mechanism involves a molecule called ADME, which PPI-Us appears to elevate. ADME inhibits the production of nitric oxide in your blood vessels. Nitric oxide is one of the most important molecules in cardiovascular health. It signals your blood vessels to relax, to dilate, to allow blood to flow freely. When nitric oxide production drops, vessels constrict. Blood pressure rises, the workload on your heart increases. And over months and years of continuous PPI use, that sustained increase in vascular resistance places a chronic burden on a heart that, in a body over 65, is already working harder due to age-related arterial stiffness. But that is not the only pathway. PPIs also significantly impair magnesium absorption. This is documented clearly enough that the FDA issued a formal warning about it. Magnesium is essential for normal heart rhythm. It is essential for muscle function, including the function of cardiac muscle. Chronic magnesium depletion, the kind that develops silently over months of impaired absorption, can cause arrhythmias, palpitations, muscle weakness, and in severe cases, dangerous cardiac events. Your heart depends on magnesium to beat in a steady, coordinated rhythm. A drug that quietly drains your magnesium reserves while you take it every morning for a stomach problem you may no longer even have is not a neutral passenger in your medicine cabinet. It is an active participant in your cardiac health, and it may not be participating on your side. Now let me move to the second medication, and this one is going to be difficult for many people to hear because it was prescribed specifically to help them sleep, and sleep is something people over 60 struggle with and desperately need. I am talking about a class of drugs called anticholinergics, which includes many of the most popular over-the-counter and prescription sleep aids. Diphenhydramine, the active ingredient in Benadryl, and most nighttime sleep formulations like Tylenol PM and Advil PM, hydroxyzine, doxepin at higher doses, and beyond sleep, anticholinergic properties are present in medications for overactive bladder, such as oxybutynin and tolterodine, and in older antidepressants like amitriptyline. Many adults over 60 are taking 2 or sometimes 3 anticholinergic medications simultaneously without realizing they share this common mechanism. because the drugs were prescribed for entirely different problems by entirely different doctors. Here is what anticholinergic drugs do to your heart, and it begins the moment they enter your system. These medications block the neurotransmitter acetylcholine, which plays a direct role in regulating your heart rate. By blocking it, anticholinergics increase heart rate, not dramatically in most cases, perhaps 8 to 12 beats per minute above your normal resting rate. That sounds harmless. It is not. A sustained increase in resting heart rate, even a modest one, forces your heart to perform thousands of additional beats every single day. Over weeks and months, that adds up to millions of extra contractions that your heart was not designed to perform. In a younger, stronger heart, this additional workload is absorbed without consequence. In a heart over 65, one that may already have mildly reduced ejection fraction, mild valve thickening, or early diastolic dysfunction that has never been formally diagnosed, those extra beats represent a cumulative burden that gradually weakens cardiac muscle fibers over time. A large study published in JAMA Internal Medicine in 2015 followed older adults taking anticholinergic medications and found a significantly increased risk of cardiovascular events and mortality with cumulative anticholinergic use. The risk was dose-dependent and duration-dependent, meaning the more you took and the longer you took it, the higher your risk climbed. And because these medications are available over the counter because they are sold as simple sleep aids and allergy pills, most people never think of them as cardiac-relevant drugs. They reach for the Benadryl because they cannot sleep. They take the bladder medication because their doctor prescribed it for urgency. Nobody tells them that both drugs share the same anticholinergic mechanism, and that together, night after night, they are quietly accelerating the aging of their heart. The third medication is the one I find most troubling, not because it is the most dangerous, but because it is prescribed so universally that removing it from the conversation feels almost heretical. I am talking about certain beta blockers, specifically when they are prescribed to older adults for mild hypertension in the absence of any other cardiac condition. Now, let me be very clear before I go any further. Beta blockers are life-saving medications for many people. If you have had a heart attack, if you have heart failure, if you have certain arrhythmias, beta blockers are essential, evidence-based, non-negotiable parts of your treatment. I am not talking about those situations. I am talking about the millions of adults over 65 who were put on a beta blocker years ago for blood pressure that was mildly elevated and who have remained on it ever since, refill after refill, without any reassessment of whether the drug is still the best choice for their body at their current age. Here is the concern. Beta blockers work by blocking the effects of adrenaline on your heart. They slow your heart rate and reduce the force of contraction. For a heart that is beating too fast or pumping too forcefully due to a specific condition, this is exactly what is needed. But for a heart over 70 that is already beating more slowly due to natural aging of the cardiac conduction system, further reducing rate and contractile force can push cardiac output below the threshold your body needs to function well. Your brain gets slightly less blood, your muscles get slightly less oxygen, your kidneys filter slightly less efficiently, and you experience this not as a dramatic event, but as a gradual, pervasive fatigue that you and everyone around you attribute to simply getting older. Research published in the Journal of the American College of Cardiology has questioned whether beta blockers provide any net benefit for older adults with uncomplicated hypertension, those without heart failure, without prior heart attack, without arrhythmia. The evidence suggests that in this specific population, the fatigue, the exercise intolerance, the reduced cardiac output, and the increased risk of falls from low heart rate may outweigh whatever modest blood pressure benefit the drug provides. Other classes of antihypertensives may achieve the same blood pressure control without suppressing the heart's ability to respond to the demands of daily life. And here is the pattern I see repeatedly. A patient was started on a beta blocker at 58 for mild hypertension. It worked. Blood pressure came down. Nobody revisited the decision. Now they are 74, and their resting heart rate is 52 beats per minute. They are exhausted by noon. They cannot walk up a flight of stairs without stopping halfway. They have been told this is just what aging feels like. It is not. It is what an unnecessarily suppressed heart feels like. And the distinction between those two things is the difference between a life of resignation and a life of continued vitality. So what do I want you to do with this information? I want you to take it seriously without taking it recklessly. Do not stop any medication based on this video. That is not what I am asking, and that is not how safe medicine works. What I am asking you to do is far more powerful than stopping a pill. I am asking you to start a conversation. This week, take your complete medication list, every prescription, every over-the-counter drug, every supplement, and bring it to your doctor or your pharmacist. Ask 3 specific questions. First, is every medication on this list still necessary for my current health situation, or was something prescribed for a problem that may no longer exist? Second, am I taking any medications with anticholinergic properties, and if so, is there a safer alternative for my age? Third, is my current beta blocker or blood pressure regimen still the most appropriate choice for my body at this stage of life, or should we consider an alternative that does not suppress cardiac output? These are not confrontational questions. They are collaborative ones. They signal to your physician that you are engaged, informed, and invested in a treatment plan that evolves as your body evolves. The best doctors will welcome these questions. The best outcomes will follow from them. Your medications were prescribed to protect you. Many of them are doing exactly that. But protection is not a permanent, static thing. A drug that was perfectly appropriate at 58 may be quietly harmful at 74. A medication that solved one problem 5 years ago may now be creating 2 new ones. And the only way to know the difference is to ask, honestly and regularly, whether what you are taking still matches who you are. If this made you look at your medicine cabinet differently, share this video with someone over 60 who takes multiple medications daily. They need to hear this conversation. Subscribe to this channel because next week I'm going to walk you through the 5 blood test results your doctor may be overlooking that can reveal hidden heart stress months before symptoms ever appear. Everything I have shared today is based on current medical research and my clinical experience, but it is general health education, not personal medical advice. Never stop or adjust any medication without direct guidance from your physician. Your prescriptions were written for specific reasons tied to your specific history, and any changes must be made carefully and collaboratively. Use this information to start the conversation. Let your doctor guide the decisions. Take care of yourselves.